Good afternoon. I'm Jeff Kahn. I am the director of the Berman Institute of Bioethics, for those of you who don't know me, and it's my privilege, honor, and a pleasure to welcome you all to this memorial symposium in honor of our colleague, Carlton Haywood Jr. I'm just saying good afternoon and welcome, and I'm going to turn it over to my colleague, Mary Catherine Beach, in a moment. I'm to remind you, as we were all chatting in the aisles here and not wanting to sit down and come to order, that we're going to have a reception to follow. So there'll be plenty of opportunities to talk amongst the group, and we all look forward to hosting you for that immediately following the symposium. With that, Mary Catherine will welcome you as well and offer some introductory remarks.
All right, welcome everybody. So, as Jeff said, we are here to honor the life and work of Carlton Haywood Jr. and to help carry his vision forward. So I'll spend a few minutes talking about Carlton. Carlton Haywood Jr. was a leader in sickle cell disease clinical research and bioethics, who died on December 31st, 2021 at the age of 46. In his short but impactful career, Dr. Haywood's distinguished scholarship and advocacy challenged the medical community to address significant injustices and deficiencies in the care of people with sickle cell disease. Carlton was born in Atlanta, Georgia in 1976. A serious and ambitious student, he earned undergraduate admission to the University of Virginia, where he found his calling as a bioethicist. Dr. Haywood graduated from UVA in 1999 with a bachelor's degree in religious studies and bioethics, and in 2003 with a master's degree in bioethics. Keen to pursue doctoral studies in bioethics, Carlton came to Johns Hopkins University, and in 2008 graduated with a PhD in health policy and bioethics. After that, he joined the faculty of Johns Hopkins in the Division of Hematology and the Berman Institute of Bioethics. Carlton was a unique and creative scholar who had both the talent and the tenacity to lead impactful, internationally recognized research on the medical condition with which he lived. His scholarship highlighted issues of injustice and paved the way for improving the overall quality of care for those living with sickle cell disease. Carlton worked generously as a mentor to numerous students, trainees, and junior faculty, both at Johns Hopkins and at other institutions around the country. Many of those folks are here with us today, and some will be speaking in a while. Dr. Haywood's service to the sickle cell disease community was also quite extensive. He served selflessly on numerous local, regional, and national advisory committees convened to solicit expert guidance on sickle cell disease. He was an active speaker at the national level. He frequently gave guest lectures in academic courses, conferences, and grand rounds at universities and medical schools around the country. Among the many awards and honors that Dr. Haywood achieved was his 2009 induction into the Alpha chapter of the Delta Omega Public Health Honor Society, and his recognition by Ebony Magazine editorial team as one of the 100 most influential African Americans in the country, who were so honored in changing the course of history and making an enduring and lasting impact in their communities and world. That he was a brilliant scholar is clear. But Carlton was also resilient, generous, patient, and kind. Under almost any circumstance, he had faith and saw the best in people. He had a fierce love for his friends and especially for his family. And we are honored to hear today to have his mother, Mrs. Harriet Haywood, and his sister Tammy here with us. Welcome. Dr. Haywood's early death reminds us of the urgent need to address the profound and persistent suffering that gravely limits the lives of so many people living with sickle cell. Carlton envisioned a world where that honors the human dignity of each person, and although his presence is missed, we hope to make his vision illuminate the path ahead. Okay. Now, I have the honor of introducing our speaker. Faith Fletcher is an associate professor in the Center of Medical Ethics and Health Policy at Baylor College of Medicine and senior advisor to the Hastings Center, as well as an elected Hastings Center Fellow. Dr. Fletcher received her bachelor's degree in biology from Tuskegee University, her master's in bioethics, humanities, and society from Michigan State, and her PhD in health promotion, education, and behavior from the University of South Carolina. Dr. Fletcher completed a National Cancer Institute postdoc fellowship in the Department of Behavioral Science at the University of Texas Anderson Cancer Center. Dr. Fletcher is a national scholar and leader in diversity, inclusion, and health equity, including her integrated public health and bioethics research designed to advance the health and well-being of minoritized populations. She's currently funded through the NIH to work with community partners and develop ethical practices and guidelines for engaging medically underserved populations in genomics research. In 2017, Dr. Fletcher was named one of the National Minority Quality Forum's 40 Under 40 Leaders in Health, a prestigious award that acknowledges the next generation of leaders primed to reduce health inequities. So with that, I would like to welcome Dr. Fletcher.
Did you go on the keyboard?
Answer.
Right on the keyboard.
Up on my, it's, I have the main thing recorded as blocking the screen.
Why is the mouse?
Thank you. Thank you for that introduction. It's an honor to be here today. I actually met Carlton Haywood at Tuskegee University in 2004. He was brought to Tuskegee as a consultant to Dr. Vanessa Gamble. And that is when I first learned of his interest and his enrollment in the PhD program in public health ethics. A lot of my work, I would say, is aligned with the work that Carlton was doing early in his career. And it's just an honor to be here before you to talk about his scholarship and his contribution, especially around respectful, ethical, and trustworthy healthcare engagement. So I'm just going to jump right in and talk about health equity considerations. And these are considerations that I have derived from Carlton's work over the years and questions that I seek to answer in my own scholarship. In this current era, are we committed to developing a structurally competent and diverse healthcare workforce to address the needs of all patients, regardless of socioeconomic status, race, sexual orientation, and other social identities? Are we intentional about evaluating structural racism, bias, and discrimination, and also describing the way that it operates and manifests in healthcare, medical education, as well as bioethics? Are we leveraging existing evidence and tools to inform equity-centered education, training, research, and clinical practice? As we think about tools and scholarship, this is especially important to me in the work that I've been doing with others over the past several years, especially around the Hastings Anti-Racism Special Report, which I'll talk about today. Whose work are we including? Whose work are we excluding, and why? Are we working systematically to dismantle harmful, false narratives about patients of color and other patients with marginalized identities? Are we equipping medical trainees and bioethicists with the skills and the training to address complex ethical issues in medicine to foster respect, equity, and trustworthiness in healthcare encounters? So I would like to keep these questions as the frame as we think about the work of Carlton and how his work really advances respectful healthcare engagement. So these are my main points for the talk. Over the next 28 minutes or so, I'll highlight that racism, bias, and discrimination not only exist in healthcare, but these factors create and perpetuate health and healthcare inequities. Addressing these inequities requires empirical and equity-centered research to inform efforts to transform medical education. And Carlton's work certainly intersected. He was a patient, he was a research scholar. He also brought empirical as well as normative analyses to his work. And again, I will use this perspective to inform what I will call the Carlton Haywood framework, and hopefully will continue to highlight a framework in the literature. So Dr. Jennifer James published an article in the Hastings Center report where she talked about patient narratives. And I feel like this really embodies some of the work that many of us are doing around dismantling harmful narratives and malignant narratives in medicine. She states that a patient who knows the medications and dose that will alleviate their pain is drug seeking. A patient who does not show up for an appointment is non-compliant. A patient who refuses to sign a do not resuscitate order is in denial. And finally, a patient who does not immediately accept a vaccine is mistrustful or vaccine hesitant. We know that there's extensive evidence, especially over the past decade, that speaks to racism, discrimination, and bias in healthcare settings. And here's an example of an article that describes racial disparities in pain management of children with appendicitis in emergency departments. Work that Carlton led or collaborated on with others in this audience talks about addressing and understanding bias and stigmatizing language in medical records. So we know that these disparities and inequities in healthcare engagement exist. We also have to create the body of literature in order to document, in order to be able to ultimately respond and address. So this article published, I mentioned by colleagues in 2018, the aim was to assess whether stigmatizing language written in patient medical records is associated with a subsequent physician and trainees' attitudes towards the patient and clinical decision-making. Again, anecdotally, we know that there are issues with medical records and writing notes and medical charts, but of course we need the empirical and systematic information in order to show that there's a need to address this, and again, to address this systematically in medical education and healthcare provider training. So some of the findings from this study included that clinician bias contributes to healthcare disparities, and that the language used to describe a patient may reflect that bias. Exposure to a stigmatizing language note was associated with more negative attitudes towards the patient. And finally, reading the stigmatizing language note was associated with less aggressive management of the patient's pain. Again, we have to continue to build this body of literature, and we have to do this in order to intervene effectively. This speaks to the importance of transforming medical education. As an ethics and public health professor at Baylor College of Medicine, I'm currently engaged with medical education. Over the past few years, I've been very interested in thinking about my training and background in health equity and bioethics to transform medical education to integrate more anti-racism and anti-Black racism content into medical education and pedagogy. We know that a growing number of medical school leaders say that health inequities are not enough. We have to really think about the social drivers and making sure that social determinants of health or non-medical factors are very much embedded in medical education. So many of us are working to do this. And when I think about Carlton's work and his impact, I think about the importance of training a structurally competent healthcare workforce. So along with my colleague, Dr. Stephanie Moraine, as well as one of our trainees, Falashade We decided to talk in response to an article, the importance of grounding medical education and health equity. So moving beyond a cultural competency framework and thinking more about structural competency. In particular, thinking about developing shared language that prioritizes equity, respect, and trustworthiness. How can we use bioethics and health equity scholarship and develop more robust scholarship to integrate into medical education? And finally, what's the importance of interdisciplinary collaboration in education as we're having these conversations about transforming medical education and developing an anti-racist medical education? We know that negative healthcare interactions diminish the trust that patients place in the healthcare system. So I'm highlighting here the Public Health Code of Ethics, and it's interesting, this morning when I had the opportunity to talk to trainees, we talked about public health ethics and essentially how to marry and integrate those two disciplines. And I talked about my experience and my training. This is an integration that Carlton did also well. I engaged with him a lot to learn more about public health ethics. And one of the major points, the takeaways from the Public Health Code of Ethics, is the effectiveness of public health policies, practice, and actions depends on public trust gained through decisions based on the highest ethical, scientific, and professional standards. So we hear a lot about patient mistrust, distrust. It's important that we shift the language and focus more on gaining public trust and also thinking about the evidence we have surrounding the diminished public trust that especially minority and other vulnerable communities have when it comes to healthcare. This is justified, warranted. We have, again, much evidence that suggests that there should be some level of skepticism. Some scholars argue that the public trust may be the most important asset for public health, and I'll add medicine as well. And I published an article with colleagues where we talked about institutional distrust and building trustworthiness in the COVID-19 response. We developed this article, again, after seeing many articles published talking about minority communities being distrustful. And in response to that, we highlighted that individuals are not inherently distrustful, and distrust at the individual level is shaped socially constructed by these collective experiences of institutional untrustworthiness rooted in systemic racism, which we know systemic racism has been called and identified as a social determinant of health and affects the quality of care that patients receive. Trustworthiness is a requisite condition to foster trust and is frequently overlooked. I have colleagues that are currently interested in expanding trustworthiness and operationalizing it a bit more so that people know exactly how to move towards developing a culture of trustworthiness. Again, it's important to identify the problems, but also to operationalize them and to provide framework so that people can follow and address some of the issues that we've talked about and we've known to persist for decades. And here I'll draw from the AAMC Center for Health Justice. Again, when we think about authentic partnerships and trust and trustworthiness, it's important to remember that researchers and providers are not the only experts. It doesn't start or end with a community advisory board. Of course, there are challenges in terms of people conducting studies, time and funding, but it's really important that we think about a more community engaged approach, a community driven approach to address issues of health and equities. There's more than one gay bar, one Black church, one bodega in your community. So again, when we think about diverse communities and within communities, there's much diversity. That's also important as we think about tailoring interventions. The project may be over, but the work is not. And that's something that I've heard much from the communities that I've worked with. What happens when the project ends? What happens when there's no longer funding? How do we sustain community health? So as we think about language, distrust, mistrust, risk populations, vulnerable populations, it's important that we think about developing a shared language that prioritizes equity, respect, and trustworthiness. And fortunately, we're in a time where there are many resources available that we can utilize in bioethics and public health and medical education. I'll highlight the AMA Guide to Equity-Centered Language. Many of us have been working on this for years, but actually having something that's documented, something that we can cite, something that we can share, resources to share with students, that really makes us think more about the terms that we're using and the context in which we're using these terms. Vulnerable communities, hard to reach communities, disadvantaged groups, high-risk groups, at-risk groups, high-burden groups. We use this language in our teaching. Carlton highlighted this in his work in terms of how sickle cell patients are discussed amongst the clinical community and encounters. So they offer this guide offers some alternatives. And again, this depends on context. It's very specific to the situation, but we can, of course, be intentional about really thinking about the cost. So communities that are underserved because of limited access, because of social economic status or structural inequalities, or because they were historically marginalized. So again, I find this very helpful as we think about moving towards equity and moving towards respect in healthcare. This report highlights that dominant narratives, also called malignant narratives, particularly those about race, as well as narratives surrounding medicine, essentially limit our understanding of the root causes of health inequities. Dominant narratives, they can create harm, they undermine public health, I mentioned the public trust, and also undermines the advancement of health equity. This is the part that I find especially important. These narratives must be named, they must be disrupted, and they must be corrected. Actually having a conversation recently, someone highlighted, well, why do we have to talk about anti-racism in medicine? Why can't we just say we're developing a racism or a structurally racism curriculum in medicine? And again, because of the embeddedness, we have to be systematic, even about the way that we're teaching. We have to tear it down in order to rebuild. We have to intentionally think about dismantling and disrupting and correcting in order to move towards an equitable healthcare system. Language matters. And I want to add that one part of my admiration for Carlton's work is that he brought his full self to his research encounters, his full self to clinical-based encounters, and disclosed the fact that he lived with sickle cell. And I know that there are many barriers to doing that, potentially consequences when we start thinking about disclosing things that are historically and currently stigmatizing. Carlton was brave, he was bold, he was fierce, and he provides an example for those of us that are in the position to highlight how our identities might influence the research questions and the approaches that we ask. And in this article, I talk about an experience as a young person engaging with healthcare and how I felt disrespected and how I felt violated by my healthcare provider. And I talk about that with students, but then I also ask the question, why do equity-based narratives matter for health? People are putting these resources and tools out. We have to make sure that we utilize them. And in some ways we can engage medical students, bioethics students in these conversations. And one of our students responded, describing or documenting in medical notes that a patient is aggressive, for example, will likely undercut future interactions that this patient has with other providers. And I thought that was really relevant and salient to this conversation around advancing health equity. So I also highlight that stories and narratives matter. I pull from a popular TED Talk, The Danger of a Single Story, Chimamanda Adichie, and she highlights that stories matter. Many stories matter. Stories have been used to dispossess and to malign, but stories can also be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. And Carlton's stories especially humanized individuals living with sickle cell and also work to empower other people living with sickle cell to talk about their experiences and other people with other conditions to share their experiences in order to repair dignity that has been broken. So I asked the question, whose stories are prioritized? whose stories are being told with accuracy, whose stories are being excluded and made invisible, whose stories are easily accessible, and who feels safe enough to share and document their stories. And that is a piece that I grapple with much in terms of who's privileged and who's advantaged enough to also share some of the things that they experience. And I don't take that for granted that I have the opportunity now at this phase of my career to talk about my healthcare experiences, and I feel safe enough to do it. As we think about the moral authority of experience and knowledge, again, I just want to highlight that knowledge and experience of all forms should be valued. Again, dismantling the hierarchy of knowledge. This is really important when we think about valuing community perspectives, valuing local knowledge, lived experiences, lived realities, thinking about bringing the insider perspective to the field of bioethics, and also thinking about shared power and authority and how can we have these conversations and engage in dialogue between bioethicists, clinicians, and other stakeholders, really to break down those silos that I argue prevent innovation from occurring. So my last point is that bioethicists are uniquely positioned to lead medical education transformation efforts. And again, some of the work that I've been working on for the past several years with some colleagues in the room, Mr. Vince Bonham, who served as an advisor to the anti-racism special report that we published in 2022 with Hastings. In this report, we talk about the importance of bioethicists being uniquely positioned, especially those with a normative as well as an empirical lens. We think about the importance of deepening these conversations around structural and social inequality so that we can bring the scholarship to medical education in the medical community. In what ways can we effectively involve minoritized groups and address health disparities with respect and fairness? How can we recognize and tackle persistent healthcare inequities? What are the strategies that can be implemented to foster a culture of trust in both research and healthcare? And again, it's important to begin to operationalize trust and trustworthiness a bit more. We need more framework. We need more description. We need more in order to think about how to intervene or what a trustworthy healthcare system, describing what that may look like. How have we perpetuated harmful stereotypes about groups in research and healthcare? And finally, how can we actively disrupt and challenge and replace narratives with language that promotes health equity? And again, I argue that the future is bright. Our medical students are actually mentoring up. They come to us with diverse experiences, diverse identities, and they're really helping us to see the importance of transforming the work that we do in medical education broadly. So we should be engaging them in these conversations as learners. So addressing anti-Black racism and bioethics, again, this is a report that I led with colleagues, Dr. Keisha Ray, Dr. Virginia Brown, and Dr. Patrick Smith. And I bring this up to add to the conversation about reframing narratives, expanding narratives. Again, many conversations we have had in the field of bioethics about trust or distrust, but we're deepening those conversations, and we're doing it by engaging scholars that have been engaged in anti-racism work and Black feminist work for years. So Dr. Yolanda Wilson highlights the importance of, again, disrupting the question of why don't Black people trust medicine? We hear this a lot, and she really analyzes this and in a very prolific way states that I begin with what is wrong with the question itself. I should say at the outset that what I have in mind is the largely public discourse around Black people's trust or distrust. She adds, this sense that there is something wrong with Black people not only further disadvantages them, but it also ignores the role that healthcare institutions have played and continue to play in cultivating a climate and an environment of distrust. Dr. Shamika Thomas, an assistant professor at Ohio State in bioethics, a medical sociologist, uses a Black feminist lens, also a former postdoc of Mr. Vince Bonham, talks about the importance of trust and centering Black women's reproductive health narratives. We are again, in a time where Black women's reproductive health and reproductive decisions are especially being challenged and threatened. And we have scholars like Shamika and others that are working to think about, again, the importance of bringing these narratives to the field of bioethics, to narrative medicine, to broaden the narrative in a reproductive ethics. She states, neglecting to center the narratives of Black women tells an incomplete story of reproductive health disparities. And this framing can shame Black women and also blame them for being complicit in their own adverse health outcomes. Here with Dr. Neka Setterstrom and Dr. Tamika Lesage, they highlight the importance of thinking about commitments of medical providers in their piece, Anti-Black Racism as a Chronic Condition. And here I'll highlight, they say, we shall stop denying that racism exists in medicine. We shall face the reality that we fail to train and equip our clinicians with the ability to effectively make informed clinical decisions using the reality of how race impacts health outcomes. And again, this is not specific to all medical trainees, so not just white medical trainees, and it's all trainees that are trained in this environment. So this assumption that we can just diversify the healthcare field so that we can have less health disparities is a faulty one. We should diversify because we have an ethical and professional obligation to do that, but we also have to make sure we're intentional about creating medical education and, again, embedding anti-racism into medical education and not assume that Black and other providers of color they're still exposed to these same stereotypes and malignant narratives about race and racism. So again, it's important to be clear about that. And it's important to think about, again, equipping our medical community with the structural competency to address disparities. So I'll end with the beginnings of what would look like a Carlton Haywood framework, and I'm sure other people will chime in when they think about his work and what that really means. Highlighting two of his pieces, one on perceived discrimination, patient trust, and medical recommendations among persons with sickle cell disease, and also improving clinician attitudes of respect and trust persons with sickle cell. So these are I would say, when I think about Carlton's work, he has many contributions to public health, bioethics, ethical, legal, and social implications of genomics work. But I want to highlight that I've learned from him that when the timing is right and appropriate, if that ever becomes the case, it's important for many of us to bring our identities to the work of bioethics, to the work of medicine, to deepen and expand existing scholarship. We should use lived experiences and realities to inform research hypotheses, methods, and praxis. We must prioritize trustworthiness, respect, and equity in healthcare. Applying a health equity lens rooted in interdisciplinary expertise is critical. And again, Carlton is one of the most interdisciplinary scholars that I know, and he worked across disciplines. And Vince Bonham reminds me of the importance of Carlton's work and how he collaborated with clinicians and clinician scientists to ensure the optimal translation that his research was relevant and is relevant and continues to be relevant for clinical practice. So these are two pictures. My last picture with Carlton. Carlton loved buffets. So we were at an Indian buffet. I think it's probably around the corner. And I want to say he got up like 4 or 5 times. Just again, it's just an honor to know Carlton as a friend, as a mentor, as a brother, as a scholar, as a teacher. And the last time I was actually at Hopkins was in 2008. And I attended his dissertation defense. And it was actually the first dissertation defense that I attended. And it was an honor to be there with his mother and his professors. And when I think about Carlton and grief in general, I'm going to highlight Amanda Gorman in The Miracle of the Morning. For it's our grief that gives us our gratitude, shows us how to find hope if we ever lose it, So ensure that this ache wasn't endured in vain. Do not ignore the pain. Give it purpose and use it. So I have to let Carlton have the last word because this talk is in honor of him. So I'm drawing from Dr. Vanessa Gamble. She wrote a tribute to Carlton in Bioethics Today. The link is below, and in her analyses of Carlton's work, she quotes him. Good bioethics in the United States should be a bioethics of race, which he defined as a conscious and systematic ethical reflection upon the role of race as an instrument of oppression in society. The goal of this effort should be the alleviation of racial injustice and oppression as they pertain to health. Dr. Carlton Haywood Jr. And here are some resources, including the Hastings Special Report, the American Medical Association Strategic Plan, Thinking More About Structural Competency, Helena Hansen and John Metzel, the AMA Health Equity Guide. I know some colleagues at Hopkins were also involved. We find many resources in the AMA Education Hub. And finally, we have to think about principles and operationalizing and expanding our understandings of trustworthiness. Thank you for your time.
So very much, yes. Thank you again for being here and sharing your work and your thoughts and giving Carlton the last word. So as has already been said, the goal of this symposium, is to talk, not only hear about some excellent scholarship, but also to talk about and reflect on how Carlton's work lives on through his impact on others. Right? We were having a conversation earlier, and Tammy, you described how you would ask Carlton how he was, and he said, fine, yes, but how are you? Let's talk about you. He constantly pivoted to the other person in the room. And as such, has left such a legacy on the rest of us. And just to give you another example of that, on March 1st, in the Virginia House, a resolution was put forward, resolution number 282, celebrating the life of Carlton Haywood Jr. I'm not going to read the whole thing to you. I'm happy to send it to you. It's a page long. It starts, whereas Carlton Haywood Jr., an accomplished scholar and professor at Johns Hopkins University and a renowned advocate for patients with sickle cell disease, died on December 31st, 2021. And then there's a whole list of whereases that highlight some of the accomplishments you've already heard. And then it comes to be it resolved that the House of Delegates hereby note with great sadness the loss of Carlton Haywood Jr., a distinguished bioethics scholar and advocate whose work made a profound and lasting impact on countless lives. And we now have 3 more of those lives to share with you, who very graciously agreed to join us today to talk about Carlton and his work and the lasting impact that he has had on them and their research and practice. First, we have Dr. Shawn Bediako. He's a senior program officer at the Howard Hughes Medical Institute, where he supports science education initiatives and leads the implementation of programs designed to facilitate institutional transformation. Prior to joining HHMI, Dr. Bediako was director of the Office of Education for the Division of Intramural Research at the National Heart, Lung, and Blood Institute at the National Institutes of Health. From 2005 to 2020, he conducted innovative research on sickle cell disease stigma at the University of Maryland, Baltimore County, where he rose through the academic ranks to become the first African-American to earn both tenure and promotion to the rank of full professor in the Department of Psychology. He is now actively engaged in mentoring and training a new generation of culturally literate researchers who contribute to interdisciplinary and multidimensional science. Next, we have Dr. Raymona Lawrence, who was recently promoted to full professor of health policy and community health in the Jianping Su College of Public Health at Georgia Southern University. Her main research focus is community engagement in rural, hard-to-reach populations, especially those with sickle cell disease. Dr. Lawrence has been an investigator on numerous rural health and sickle cell disease-related grants, and is currently a dual PI principal investigator with on a $9.7 million PCORI or Patient-Centered Outcomes Research Institute grant entitled Comparative Effectiveness of Peer Mentoring versus Structured Education-Based Transition Programming for the Management of Care Transitions in Emerging Adults with Sickle Cell Disease. Dr. Lawrence is committed to diversity, equity, and inclusion and holds the distinction of Certified Diversity Executive. She is an award-winning coach for the National Center for Faculty Development and Diversity and serves as Director for Research for the Sickle Cell Community Consortium and as Editor-in-Chief of the Journal of the Georgia Public Health Association. Dr. Lawrence. And finally, we have Dr. Gyasi Moscou-Jackson, who is currently the Director of Nursing Inquiry at the University of Maryland Medical Center. She came to UMMC after working as a program officer at PCORI, the Patient-Centered Outcomes Research Institute. She obtained her PhD in nursing from the Johns Hopkins University School of Nursing in 2015 and has over a decade's worth of experience in research that focuses on improving patient outcomes and healthcare delivery with a focus on clinically vulnerable populations. She's been the principal investigator on 4 nursing research studies and has received research funding from the Daisy Foundation and the National Institute of Nursing Research. She's also a leader and mentor in research and evidence-based practice, mentoring undergraduate nursing students and clinical nurses in the spirit of inquiry, question development through dissemination of the project, and question development through the dissemination of project findings. So we've asked each of our panelists to provide a few minutes of remarks, not only anything they would like to reflect upon from Dr. Fletcher's lecture, but also to talk a bit about, as I said before, the lasting impact of Dr. Haywood's work on yours. Thank you. I think we're starting with you. No.
Good afternoon. Can everyone hear me okay? Great. It's always a little bit confusing when different types of worlds collide, where as intellectuals or researchers or scholars, you're asked to talk about your work. And I think, you know, most of us, many of us here can easily do that. When it comes to talking about the personal, often those things are orthogonal to one another, and we don't really have those opportunities. So I'm not apologetic for this clash, but it does say something about the system in which we operate when people are not allowed to bring their full human experience into spaces and places. So I'm only saying that because I might cry and that might scare some people in here. And I just want you to be okay and know that I'm okay if that happens. So, because we're humans, I'm human, and this is where we are because I was really blessed to have the opportunity to know Dr. Haywood, not only as a formidable scholar and a careful mentor, but also just as a friend. And it's in that capacity that I miss him so much. And so I'm gonna talk a little bit about what that means, and I will be bridging some of these gaps. So one of the things that I wanted to say first is it's not fair to offer comments after Dr. Fletcher has like provided so much for us to really think about. And I think I'm being set up for going first. So y'all are welcome. You're welcome. But one of the things that I thought about is really the fact that there are, in my view, two ways to achieve relative immortality. One is through scholarship, writing things down. The other way is through songs. For those who know me, I'm a musician, so I am trying to hedge my bets on both sides of the thing. But I say relative immortality because the song only goes away when no one remembers how to sing it. Same sense with the scholarship only goes away if no one is there to cite it. And I think that with Carlton, he is carrying the baton of generations of scholars and has passed the baton on to another generation of scholars who will pass the baton on to yet another generation of scholars. And so in that way, I think that his legacy is set, but it's not safe if we forget what it was that he brought us and what it is that through his work, through his scholarship that he's taught us. So I think that Dr. Fletcher has reminded us about the importance of writing things down. That's what scholars are, right? People who write things down. It's not contingent upon degrees or rank or title or any of those things. In our conversation earlier this morning with Dr. Khan and Dr. Matthews, I mentioned the fact that I first met Carlton around 2004, 2005, maybe. And I moved here partly because of the opportunity to be able to work with him. We became good friends, but I guess not good friends enough for me to realize I was thinking that he was a peer of mine. I came here in a tenure track faculty position. And as Faith mentioned, he defended his dissertation in 2008. And we were cool for like 3 years. And he told me like, oh yeah, man, my dissertation, my defense is tomorrow. And I'm like, wait, what? Like, you're not, like, I thought you were a professor at Hopkins. He was like, and I'm like, wait, still, like, what? So, I say all that to say that the importance of writing things down, the importance of being able to translate ideas into frameworks and models that not only move practice forward, but in those rare special cases, actually transform the way that we do an entire thing. And that was my experience of Carlton. Again, I mentioned that this morning. Before interacting with him, I thought of research and scholarship as purely transactional. It was something that we do to achieve some other end that usually is tied to something related to rank or promotion, right? And I think that it was through him I learned how science becomes alive when you put a human face and a human story in it. And my career, my life has not been the same since. And I think we could talk a lot about the scientific aspects and the scientific elements here, but the key takeaways that I have is that what we write down as scholars does not have to be impersonal. It does not have to be dispassionate. It does not have to be transactional, and it definitely does not have to be neutral. And I think the sooner that we disabuse ourselves of the notions of all of those things, we'll finally start to see all of this work that we produce start actually making a difference in the world. And not making a difference for our research programs, making a difference for the world. Mm-hmm. And I think that connection to the public trust is very important. Two more things, and then I will pass over to Dr. Lawrence. Dr. Fletcher talked about the importance of naming, disrupting, and correcting. And I thought about that each one of those aspects has a corollary attached to it. So with naming, you have to be paying attention to hear when something comes up so that you can, oh, that's X. That's what that is. You have to be paying attention. right? With disrupting, you have to have intention. You have to do something purposefully. You have to say, we are going to do X because we want Y outcome. We want to change this thing, so we're going to disrupt it. And then finally, for correction, in order for something to be corrected, you have to have knowledge. And that knowledge has to drive what it is you're going to replace it with. And we get there when we do those things that she mentioned. Bring from the Haywood framework, bring your identity to the work, use the lived experiences. Those things really resonated with me. And the last piece that I thought was very important was collaborate and the importance of collaboration. And I'll tell you one of the things that I learned from Carlton, because and Mrs. Haywood may disagree with me, but Carlton was like the brother I never had. And we were such good friends to where whenever we got together, the first half hour, I was just trying to argue with him because I knew he was so smart. And I'm like, instead of asking him for feedback on my ideas, let me give him something real provocative and compelling and act like that's my position. And then see what comes out of that. And it worked like a charm. So I got so much smarter talking to him. But I learned from that the importance of collaboration, that you don't always collaborate with people who see things the way you do. And one of the key lessons I learned that was probably really helpful for my career was being able to collaborate with people I did not agree with. And I probably have gotten a lot more out of those collaborations than I probably would have if I had only just collaborated with people who already agreed with me from particular starting points. So with that, I'll end, but I'll just say that it really is an honor to be here today, particularly to be able to sit between people who in many ways close a circle for me, because I met Faith actually through Mr. Bonham, and I didn't realize that we both knew Carlton the way we did. And it was like, once that was established, we cool with each other. Like we were so cool. And the same with Dr. Lawrence. We met at the end of her graduate training, I believe, when she was just starting out in the tenure track faculty position. And now to see her sitting next to me as a full professor, like, actually says I've been in the game a lot longer than I want to give myself credit for, but it also just shows the importance of what happens when you plant seeds and invest in other people like Carlton did. So I'll pass over.
That's an excellent segue into me talking, because Carlton was my mentor. He was a mentor. He was a friend. He was just so much as he was to so many of you out here. And when I came into academia, I knew nothing, right? So a lot of times we start this job and we don't know what we're doing. It feels very unwieldy when you start an academic position, and that's where I was. And I needed help. I needed somebody. And I met Dr. Bediako and Carlton around the same time. And as I was telling his family earlier, he was like a big brother. He didn't judge. He just said, here's my my NIH LRP, here's how you write it. He gave me the information that I needed to be able to be successful. And so Carlton also became formally my mentor within the PRIDE program, which is a program for scientists within the NHLBI. And so as he became my formal mentor, he brought me out to Johns Hopkins. He gave me opportunities to present and to learn how to speak the academic language and how to navigate these circles. But Carlton did that for me, but he also gave me courage. because I got to see Carlton as an individual who had sickle cell disease, who was basically killing the game, right, as we say. And so he was out there and he was doing the work. He was getting the grants, he was writing the papers, he was making a difference for people that had sickle cell disease. And he had the courage to speak that. And that was so important for me because I have SS as well. So I got to see somebody else do it and rise to the top and show me how it was done, even if you didn't feel good, if you were in the hospital, if you didn't have the strength that particular day. You get up, you keep it moving, and that's what Carlton did. And so it really gave me a voice in academia as well as in my own world. He gave me that voice to be able to speak about sickle cell disease. And so I really learned to love community engagement from Carlton. And so the work that he did with individuals with sickle cell disease and out in the community, he taught me how to move up the community engagement continuum. So I know that you all have probably seen that when we just do outreach, right? We say we want to work with people that have sickle cell disease. We're the researchers. We sit in a room and we say, here's the great thing I thought of. Don't you like it? And will you do it? And when there are people with sickle cell are like, no, it doesn't work in my community. And so I learned how to really bring in those voices and move people and move research from the bench to the bedside to the block, so that people actually used it and they were excited because they really had that bidirectional education. They had that learning and they had the ownership in things that they were having come into their communities. And so Carlton gave that to me. He also gave me this idea of, when you were talking about Chimamanda Adichie, that is such a powerful TED Talk. So if you all have not seen it, please go watch it. I watch it all the time because the idea of it is that there is danger in a single story. Right. So the power of the power is in the hands of the individual who's telling the story. And so when we have that power, that is great power that we really need to ensure that we are using in the right way. And I've learned that in sickle cell disease, we often don't have the voice. We start the sickle cell story with a person being angry or in the hospital instead of with all of the things that they've gone through before that. And so the narrative about people with sickle cell disease is so very skewed because we start the story in the middle, right? Instead of at the very beginning of the story. So Carlton taught me, bring in people's voices so that you can make sure that the entire story is told and it's actually told from their perspective. And so that is one thing that I absolutely have used in all of the work that I do. I do a lot of qualitative research because I love to have people's voices incorporated into the work that I do. Another thing that I really learned from Carlton in diversity, equity, and inclusion work, we talk about this idea that we recruit for diversity, but we onboard for conformity. So when we recruit, we say, we want to hear your perspectives. We want to see all the things that you are doing and how life is different when you navigate the world. But then when we bring people in or we develop these programs for them, we say, you got to do it this way because we work 9 to 5 and you got to make sure that you do that. We get there this way. And so things don't work. There's not the connection. And so we have to stop recruiting for diversity and onboarding for conformity and start to develop programs that really are in line with how people with sickle cell disease live their lives and how they are truly going to be engaged so that we're not just telling them do it our way or else. These narratives that we start to perpetuate. So, and then the last thing that I'll talk about is that we really have to start to think about the fact that engagement can harm. And a lot of times people don't think about that. They don't think about the fact that if we engage in our own way and we do that in communities with the same exact people, we develop divisiveness in communities. We don't do things the way that they are set up for that particular community, then we can harm a community. And so when I think about Carlton and I think about all the things that he taught me that it's not important to have academic metrics. It really matters what happens at the end of the day with that individual. And that is what we have to drive ourselves on when we're doing our academic work. And so I'm really passionate about making sure that now we move research and make sure that it's the community is a unit of analysis versus this research that we normally do, right? Where we just have the researchers and we say, well, let's look at acute care utilization and all these things. They're great, but what is it that the people really need? And so how do we move? Again, my summary point is from the bench to the bedside. To the block. To the block, yes. So thank you all for having me.
Well, I think what they said will be a lot of what I would say in mine, but it's great to have this forum to think about how one individual can impact so many lives that take it in so many different directions that ultimately together we will all bring everybody's collective work together to really solve the issues and problems that, we're facing. But so I was a nurse, or I am a nurse. I shouldn't say was because I still am, but I'm a nurse. And I had gone, as you heard, to Johns Hopkins for my PhD in nursing. And when I started there, I just had this broad idea that I was going to focus on cardiovascular disease. And I had a research training grant to focus on cardiovascular disease. But in talking with my advisor at that time, I realized I don't really want to focus on heart failure or hypertension. I really wanted to, focus on something different. And it was through my advisor at that time who had learned about Dr. Haywood, who said, hey, why don't you go and, speak with him? And I was like, great. This sounds like a good avenue that I would love. I think that I would love to learn more about sickle cell disease and see how I, as a budding researcher, could impact this community. So I went down, came down to the Ashland building, and I sat down and I talked with Dr. Haywood, and that's where he really turned into being my mentor as well as teacher. And I feel like I've learned so much from him along the way. We just kind of sat there and we just talked about his life, the work and the research that he had done up to that point, and just the challenges that he was facing. And it's where, in talking with him, I really came to learn about some of the potential sleep challenges that he was facing, in addition to the pain that he was experiencing. And so I said to myself, and we talked about it, and I said, I really want to explore this idea of sleep. It's one of the symptoms that I feel like maybe we're not talking about as much, or we're not thinking about it, and has such a reciprocal relationship with the pain that you're experiencing. And that's what I want to focus on for my dissertation. And so I realized, in thinking back on, what I took away from that first conversation, is it was my first experience with patient-informed research, and really whose expertise matters. And really listening to his story, or through listening to his story, where I walked in the building thinking of him as a researcher first and a patient second, I really switched to thinking about him as the patient first and the researcher second. And really, how do I bring that narrative into the work that I'm doing? So he brought me along with the journey, and I really was like, it wasn't that sickle cell disease was thought of as a cardiovascular disease, but I was determined to, have my work focused there. And so we worked together to really conceptualize it in that way so that I can continue with my training grant. So through my work with him, I really he really instilled in me the advocacy for the challenges that patients with clinical vulnerabilities, as well as their families, experience. And really, how do you even though I was focusing on sleep and sickle cell disease, how do you take what you're learning and really think about advocating for other groups and other populations as well that may be facing the same challenges? And so translating those lessons became something that I, have continued to do as well, in addition to staying true to my roots. So after I finished, I went on, as you heard as well, to work at the Patient-Centered Outcomes Research Institute, which was really focused on making sure that all of the stakeholders are at the table, that we not only consider the patients and their families, but also the other stakeholders that will help to ultimately better inform the research that we're doing and figuring out what are the medical decisions or just the issues and the solutions for those potential challenges. And so I, because of my work, I worked on the Rare Disease Advisory Panel. I helped to bring along one of our funding announcements, which she was a recipient of, that focused on transitions in care for emerging adults with sickle cell disease. And it just really continued to fuel my my passion for engagement in research, and really the benefits of engagement in research, although there's still a lot of that, we all have to learn about how to do it well, I can tell from this panel. So fast forward, I feel like now in my current role as the Director of Nursing Inquiry at the University of Maryland Medical Center, that's where I really feel like I'm sort of bringing it all together. I not only in this role have an opportunity to mentor as well as remember, to not get too far from that human experience of thinking about, and one of the things I feel like I learned from Dr. Haywood as well is it's not sickle cell disease patient, but it's a patient with sickle cell disease. And so many people, again, are like patients first with their disease second. Mm-hmm. And so that's something that not only I take away in my own work that I'm doing, but also have an opportunity to mentor other clinical nurses as well as they work with patients. Also, just advocating for reinstating our patient experience council, which I think with COVID, a lot of things got put on hold, but that's such an important council that while just one person's experience, as we heard, I feel like that gives people a voice to talk about their experience, from which then we can go and explore further to see whether or not it's something that others are facing. And so I think it's really important that we are working towards having that council and really using that as a way to understand how do we better provide care. I also have tried to bring in some ways of challenging us to have those discussions around diversity and equity and inclusion through things like our nursing grand rounds, and really having the presenters talk about how that might impact their work. And what I'm really excited about right now is this next thing that I will be doing, which is focusing on an environmental health research institute, where I'm really, in all of the work that I've been doing in the environment that I'm in, which is in a health system, really thinking about how that physical structure of care is a complex environment that's filled with so many social and cultural norms, which I think we talked about, and how do we improve that. I mean, it can either improve a person's health or it can detract from a person's health in so many ways, as well as their experience. And how do we continue to focus on that? Which we talked about. While we know there's so much that goes into it and there's so many things that could go wrong, we still haven't solved that problem. And so really thinking about how do we continue to move that work forward, and how can I be a part of that solution so that we help people ultimately benefit and leave our healthcare system with better health than they came in with, I think is really important in the work that I'm doing. So that is my story, and how I think that, his Dr. Haywood's work lives on through me. And I'm really thankful for just having the opportunity to reflect on it, because I think, as Dr. Bediako said, like, just that when people forget, when you stop remembering and you forget that piece of it. And so it's really important that, we all have this opportunity to reflect on where we came from, where we are, and where we can go next, and continue to have these discussions as we move forward. So thank you.
Thank you all so much for sharing your scholarship and your reflections with us and giving us this opportunity to remember Dr. Haywood, of course. One thing that really struck me from this set of comments was not only the sort of common threads of Dr. Haywood's impact, but also I think, Dr. Moscou-Jackson, you reflected different paths that impact has taken, right? And so I'm a geneticist by training. Folks in genetics often talk about our intellectual lineage, like who was your PhD advisor and who was their PhD advisor, et cetera. But I feel like for Carlton, we need a network analysis. Like where did all those tendrils go, right? Which different disciplines got woven together through his relationships with people? I think that would be just a wonderful and incredibly interesting exercise. But we do now have time, and we have about 15, 20 minutes for questions. I invite questions from the audience. I know we have a mic somewhere in the back of the room. And also, if any of you have questions for each other, that is great as well.
I do have a question for Dr. Fletcher.
Yeah.
One of the things you mentioned was about the importance of medical education, kind of being transformed to be, or really for health equity principles to be integrated into medical education. And I'm just wondering if you have any thoughts about what that should look like in either its like initial rollout or in incremental steps, or like how do you propose that we go about kind of changing a system that has persisted for centuries pretty much?
It's certainly going to take funding and investment. I think a lot of people have an interest in doing this, but if we're not provided with time and effort to do it, that creates a challenge. I can say from my work, my interest is really thinking about, again, bioethicists and their roles in advancing this. And I feel like we can bring the literature that's interdisciplinary and robust. And a lot of that has already, it's been done, the work has been done. So Carlton's work is a good example. Now we need a Carlton Haywood framework that we need to integrate into medical education. So from a scholarship perspective, I feel like my interest, and we did this with a special report, is to really bring things to the bioethics literature so that that can be disseminated within the medical education culture. So that's where I sit, and that's the work that I believe that I can do and I'm passionate about. And yeah, I see all kinds of opportunities with all of our work and all of our talks and how that could be threaded together and really used as an example for med ed.
And I'm not trying to badger you.
No, you're good.
So I'm hearing you say like the funding piece could help to drive curricular types of
Evaluation. We have to
Okay.
make sure that we also are evaluating. How do we know if the transformation is when it's transformed? We need to make sure that we have metrics. We have to bring in social and behavioral scientists into medical schools, people that have training in education pedagogy. It's not just something that you can just decide to do one day, like I'm an expert in curriculum development. And we see that a lot. So we have to make sure that we're hiring the people to do the work, and we can assist as people with public health and health equity and ethics training. So yes, being very systematic and strategic about doing it and making sure that we have metrics in place to think about the long-term impact of the work that we did.
Okay. You said social and behavioral sciences, so I'm satisfied. Thank you. That's all I need.
Okay.
Thank you. Appreciate it.
And you also talked about bringing in the experts, which I definitely appreciate, because I feel like there's so many times where then people are not brought to the table and those conversations don't go anywhere, or they don't go anywhere effectively. So making sure that the right expertise is at the table is so important.
Yeah, completely.
I had a question just to follow up on that, if you could
Ask
describe. Oh, maybe.
So the Zoom audience can hear.
Oh,
Thank you.
yeah, so I wanted to follow up on Sean's question, sort of, we talked about measuring those metrics, but could you describe what some of those metrics might look like?
Mm. Well, that's a good question. I'm actually not creating those metrics, but there's a lot out there. AIMC, the American, what does the I stand for? AIAMC. There's a conference and medical educators are getting together and bringing their best practices together. AAMC has really good work. American Medical Association, Center for Health Equity. So there are resources out there. I think we also need people that can bring those resources together. I think there's a lot of underutilized resources in those spaces as well. So again, there are some people at institutions that are going to conferences that are doing some of this work. I'm not involved in that aspect of it, but as a social and behavioral scientist, I know that we're needed to, yes, to definitely think systematically about what it is that we're trying to do and what we need to measure. And that work is happening now. And there are institutions that are doing a good job. And I think there's some work at Temple that can be served as that can be used as a model. And everyone I feel like is trying to think about ways to do it. But yeah, we just have to look at the best practices and figure out the funding in order to be able to do it. But that's a good question.
Can I ask a follow-up question to that?
Sure.
So the metrics that you were just discussing are specifically about the impact of on education. Is that-
Attitudes. I mean, there's work already at the undergraduate medical, John Metzel's work and Helena Hansen's work. I mean, they exposed medical trainees to a structural competency curriculum and then measured like their attitudes, perceptions.
Mhm.
So those types of pre and post measures can be implemented, but actually, and we think long-term in terms of even the impact on patient outcomes, patient satisfaction. And again, this work is happening. It's just being systematic and breaking down those silos. I meet people all the time. They're like, oh, I'm working on this. And it's like, oh, I'm working on that. Like people should be talking more. We have to be more systematic about that.
Academia is very good at silos.
Yes.
Gail and then Mary Catherine.
Hi, so thank you so much for fabulous talks. I have some involvement in medical education here at Hopkins. I think a real underutilized resource are the students, the current students who are involved in our curriculum review right now. And one of the problems that we're coming up against is that it requires a fair amount of faculty development. And sometimes we find that the students are much, much further along, much more sophisticated in this thinking than the older professors who are teaching them and continuing to use offensive language or continuing to cite materials that have sort of, embedded racism in them. And how to tackle that problem of faculty development is a real challenge. It's not enough, I think, to just educate students, but the students who will become clinicians, how to think differently and how to behave differently. But the people who are teaching them now really are going to have an impact on them.
Okay, thanks. One of the things that has struck me as you guys were talking is how there are so many similarities in your academic work. And I want to pay a little bit to the fact that Carlton identifies strongly as a bioethicist. And yet a lot of the times he was the only Black bioethicist in the room. And we have recognized that, bioethics tends to be a very white field. So I'm kind of wondering, Dr. Fletcher, how did you start thinking about a career in bioethics specifically? Like, how did you begin to align conceptualize your work as being part of bioethics. And then you guys, the rest of you, do you think of your work as bioethics? And if not, do you know like why? I'm just curious about.
So I really just became a bioethicist in 2019. Before I was in schools of public health, and I just, I was perceived as a person that had public health and some bioethics training, but without having the bioethics infrastructure at those institutions, it was really challenging to say, oh, I'm a bioethicist, I can do this work. So I think a lot of it for me, I had the training. It was my network of bioethicists from Tuskegee, working with Vince, meeting Carlton, going to Michigan State, and then essentially, and we talked about this, and bringing those disciplines together. And one day NPR said, Faith Fletcher, bioethicist, and then magically bioethicist. So I'm like, I'll take it. And I've been rolling with it ever since.
I didn't know NPR had that power. That's amazing.
Yeah.
Yeah, I guess I would say maybe because maybe similar to you too, like I came into nursing and that's been my identity. And I think, right now I'm growing into this field. I had an interest in it, but I haven't quite gotten to that phase where NPR is giving me that title too. So, perhaps that will come in the future. But in the meantime, while not formally recognized with that title, I appreciate being recognized with that expertise and that and bringing that expertise to the table in those discussions and really thinking about how I can still move it forward without those conversations forward, even without that title, is important.
I personally think of myself as a public health practitioner. And so when we are trained in public health, we're often trained to be the bridge. And so we're trained that you're going to be in a room and people are going to have all different perspectives, and you're going to have to be the person that sees a little bit of everybody's perspective and bring it together. And so that's how I've always been when I've been on a team or wherever I was. I always try to think, oh, this is what the physician thinks. This is what the patient thinks. This is what whoever else is in the room, the payer thinks. And so that's how I come to every conversation. And so I don't necessarily, I've never called myself a bioethicist, but I think that I am the bridge between the different disciplines.
Yeah, I'm quite unorthodox. I think I have struggled my whole career with the way that the academy is organized. I see myself as a person who thinks, a person who writes, and a person who tries to solve problems. And I can sit down with a physicist, a philosopher, an artist, a painter, public health professional, and an NPR validated bioethicist, and just talk to them, because I think that's just how I kind of approach this. So I would love to be called a bioethicist. I'm gonna call NPR and see if I can structure an interview. But I see those labels not necessarily being arbitrary, but I think one of the things that I took from Carlton, because I never felt intimidated by the wealth of knowledge that he had. And he could talk on so many different topics and was familiar with so many different literatures. But what I learned from him, that what you do is probably more important than what is called.
Yeah.
And as someone who's a social psychologist, which is even in the field of psychology, I'm kind of considered, one of the outsiders or on the margins. But then I'm a social psychologist who's also a health psychologist, who's also a community psychologist, who's studying sickle cell. And so I was just striking out everywhere. And so, and I'd say that in jest, but, literally when it came time to go up for promotion and tenure, and I'm struggling. trying to figure out who could evaluate my work. The social psychologists didn't care about the sickle cell work. All the sickle cell people I knew were physicians, and my department was not going to ask somebody with an MD to evaluate my promotion and tenure in the psych department. So I was just like, let me just, just pulled out some names and like, let's just see what happens. And, you know, it worked. But I think that's one of the things that, you know, to Mary Catherine's point, it's like, it's a tension between how do we think about equity and inclusion, but how do we think about it like within the current system and within the current model, but also the challenge is like, how do we think about it outside of the model? So, you know, I think those are some really interesting questions, but I think as we start to move more and more towards this multidisciplinary and interdisciplinary ideal, if we're really serious about that, it's really bringing up a lot of questions, tough questions that we're going to have to answer in some ways. Yeah, I'll stop there. There's a whole lot more because I work in science education, and this is like my job to kind of think every day, like, how do we change this whole system? How do we transform it? And, you know, so I'm able to kind of think outside the typical parameters around some of these things that I know will frighten some people, but it may also kind of open things up in a way to where partly because, and so I'll just say this, and I promise this is the last thing. The thing that's interesting about it is there are a lot of Black people doing bioethics
work
and don't know, like, you know, I'm not gonna say they don't know, but they're not called bioethicists, right? And so that's another whole piece here too, to kind of add to that, but you know, so I'll stop.
Yeah, please.
Thank you. Do we have Dennis? Yes, please.
First, I just want to give honor to Mrs. Haywood because we wouldn't have this conversation about Carlton if we did not have the experience that he had coming, being grown, developed as a young man. So I just want to say thank you. Because of you, we all connected with Carlton, the man. So you helped to develop the board. So my question is, in 2024, today, in March of 2024, we now have 2 new gene therapies for sickle cell disease. We are having across this country a challenge around comprehensive healthcare for individuals living with sickle cell disease. We're having a pushback around issues of equity and diversity and inclusion in institutions across this country. What would Carlton think and what would Carlton do? So it's a good question. What would Carlton think about where we are in March of 2024 in this country, and what would he do?
Start.
No, I think you start. Go ahead, Shawn. You got a lot to say.
So one of the things I think when you move from intelligence to wisdom is knowing when to not answer a question, when to pass it on. And so my wise people have turned this over to me and say, you go first, but I don't know that I could do justice to what Carlton would do or to how Carlton would think about it for sure. In terms of what to do, I think he would be chomping at the bit to get at the problem because it is complex, complicated, and intersectional. There's not one single answer. And I think one of the things he would enjoy would be sitting at a table with people to throw out ideas that can be shaped, refined, debated, discussed, and just enter into a critical dialogue about what the next steps might be. And I think for me, I just think he would say we have to try to do something. And I would dare go out on the limb to say that I think one of the things that we find as being a particular challenge about the current context that you described is that it seems like it's so much that everybody does nothing. Right? So it seems like it's so much that everybody just feels like, I don't know what to do. And so let's just go back to the status quo, or let's just go hide out and work on something else. But I think that he would approach the challenge of doing something by first understanding that we can't do it alone. We have to do it in collaboration with one another. And that the sky's the limit in terms of like, how do we think about it? Let's get our boldest, riskiest ideas out there and see what change we can make. And even if the needle moves just one iota, that's still an incremental difference from where we were. So that's what I think he would do. How he would think about it, like I said, that brother is like an ocean of knowledge, and he might have been the person to say, "Oh yeah, well, easy, let's do this," and he'll have the proposal ready tomorrow. But I do think whatever approach that he would take would be something that's collaborative, that draws upon multidisciplinary and interdisciplinary strengths, and something that's purpose-driven to bring about real change. So identifying the problem for what it is and not getting caught up in a lot of the reactions to the problems, but directly addressing the problem head on.
Does anyone else want to?
I think Carlton would say there's nothing new under the sun, right? So Sickle has always had challenges, and we just call it a new name every few years, right? So we've always banded together. We've always worked to make sure that we address things as they come, different name, but the same story, right? And so I think he would call us all up and say, hey, here's what I need you to do. Here's what I need you to do. Let's get to work. And he would move forward with it. And so I think Carlton would be hashtag unbothered. He would say, this is what we need to do. He would get us to work.
From an ethics perspective, I think he would remind us that he's been working on these issues of race and racism long before race and racism and bioethics became a trend. And like that quote said, good bioethics is a bioethics of race. And I believe that he would continue with that framework, with that way of thinking, and remind us and challenge us as ethicists to be bolder and braver and broader.
Yeah, I don't think I have much to add to that, but I just remember him being sort of calming, not necessarily, not that he wasn't the most vocal in the room, but he definitely had a calm spirit about him that commanded the attention of everyone, and everybody knew that he had an expertise to bring to the table. So I could see him, being at a seat at the table, which I had seen him do when I was at PCORI in our stakeholder meetings, sort of be that voice at the table that would ask the tough questions and challenge people to think innovatively about the solutions. So that's what I think I would, picture him doing if he was here today.
So Vince, I have to thank you for ending this conversation on forward motion and on action. And I love and completely agree with this combination of unbothered and let's get to it. So I think that's a great way to wrap up. Thank you again all for sharing the topic. And I'd like to invite you all to join us for some refreshments behind those doors. There is food and drink, and we have some standing tables at the back. Please stick around, get something to eat, continue the conversation.
Y'all are amazing. Y'all are amazing. Y'all are awesome.